morning, and thank you very much. Tough act to follow, Dr. Waleed, but I am truly honored to join you here today, and thank you to Dr. Joera and the organizing committee for including me. Honored to join my colleague and friend, President-elect of the American Heart Association, Dr. Stacey Rosen. And what I'd like to do in the next 25 minutes or so, discuss with you what imaging modalities are available and which algorithms you should use in evaluating women presenting with chest pain at risk for cardiovascular disease. So what I'd like to do is put this and frame this into the context of why we should be focusing on early and accurate diagnosis of ischemic heart disease in women. You've heard the facts yesterday and today that cardiovascular disease continues to be the #1 killer of women. Dr. Rosen gave us a lifespan approach to cardiovascular disease in women, and I think as we put it into perspective, cardiovascular disease, ischemic heart disease, the leading cause of morbidity and mortality for women worldwide, the key to reducing death and morbidity from cardiovascular disease is early diagnosis. So we will discuss the evidence to support the need for a continued focus on early detection, and we'll use a case-based approach to highlight the evolving evidence in helping us determine which women would benefit from which non-invasive diagnostic test. This slide you've seen yesterday, but it is a reminder that our work continues in terms of reducing the global burden of cardiovascular disease as set out by the Lancet Commission by 2030. The magnitude of the problem highlights the fact that cardiovascular disease continues to be the leading cause of death of men and women in the world, and that truly, when we think of women's health and some of the challenges, we know that it's understudied, under-recognized, underdiagnosed, and undertreated. If we are indeed to reduce the number of women dying from cardiovascular disease, ischemic heart disease, early diagnosis is of critical importance. What is the evidence so far? Approximately 24 and a half years ago, the American Heart Association launched the Go Red for Women campaign. There was a threefold mandate. One, to increase awareness, because we recognize that up to 80% of cardiovascular disease is preventable. Second, to study the science, the sex and gender aspects of all aspects of cardiovascular disease to empower not only women, but the whole medical community that we can detect and treat and prevent cardiovascular disease. So we have come a long way. And in 2022, the presidential mandate from the American Heart Association, and spearheaded by the luminary Dr. Nanette Wenger, who Dr. Waleed mentioned, issued an additional call to action, highlighting the fact that we needed further sex and gender research, we needed to increase awareness. Because we look at the reality of women's health, we see that only 44% of women ages 20 plus or over are living with some sort of heart disease. And importantly, when you look at the knowledge base, you see that only 42% of members of the medical community know or feel equipped to treat women with cardiovascular disease, with ischemic heart disease. And so our work is not done, it has to continue. And I think an important point from the presidential mandate highlighted that when we compare health data from women to data from men, and we know that women are understudied, as highlighted by Dr. Rosen yesterday, we can lead to conclusions that men's health is the gold standard and women's health is atypical. So it overlooks the unique biology and life stages of women. And so the call for us to look at women in clinical trials as critical to us understanding all of the sex and gender differences is important. And this is also true for cardiovascular imaging. So what have we learned in terms of the presentation of ischemic heart disease of women? And many of the cases presented showed you some of the nuances. From the landmark PROMISE trial, spearheaded by Dr. Pamela Douglas of Duke University, looking at CT, looking at non-invasive imaging, when we look at the symptoms, we see that both men and women with ischemic heart disease will present with some sort of chest pain. And it had led years ago to us saying women's symptoms were atypical. We have now abolished that term, and any sort of symptom, you have to rule out ischemic heart disease until proven otherwise. But these data show that in the over 10,000 patients, symptomatic patients enrolled in PROMISE, chest pain was the predominant symptom for both men and women. We have, however, to be on the lookout for additional symptoms: back pain, fatigue, palpitations, dyspnea, presenting as the inaugural sign of ischemic heart disease in women. So what this tells us, because in evaluating a woman with chest pain, looking at the symptoms, definitely important, and then looking at the risk factors, also important in us determining which test will give us the answer to the cause of her symptoms. Additionally, as we look at the evidence, we know that women up to date have had suboptimal cardiovascular care. These data, a combination of data from several studies highlighted and presented by Dr. Leslie Shaw in one of her keynote addresses at the ACC last year, shows that there's pervasive undertreatment and underdiagnosis. Women receive less aspirin, beta blocker statins, antiarrhythmics, and women encounter inequities in symptom recognition, as well as in disease presentation and diagnostic testing. And again, as we continue to reduce the burden of cardiovascular disease in women, we must definitely implement guideline-mediated therapies. And so ongoing evidence to show that we have to be laser focused on choosing the right diagnostic test for the women at risk for ischemic heart disease. We have also learned, and you've heard this over the past day or so, that there are diverse mechanisms of myocardial ischemia. You heard from Dr. Walid about SCAD. Additionally, we know that the spectrum of ischemic heart disease for women involves epicardial coronary arteries. We also know that the coronary microvasculature is affected, and the endothelium, all can lead to symptoms of ischemic heart disease. And we also know from a prognostic point of view that ischemia in the setting of non-obstructive disease, INOCA, is not benign. As we consider this, and as we consider diagnostic testing, looking at things like resting blood flow, myocardial mass, coronary anomalies need to be included in our equation or algorithms for evaluating the woman with suspected ischemic heart disease. And so you put this together, and we know that the evidence to date supports the fact that ischemic heart disease, leading cause of morbidity and mortality for women around the world. We know that sex-specific differences exist in the pathophysiology, as well as in the performance of differentiating for non-invasive tests, and it necessitates a sex-based diagnostic workup. And whether we choose functional imaging or anatomic imaging depends on the symptoms, depends on the risk factors. Ultimately, algorithms must include functional, anatomic, and physiologic assessment to evaluate the full spectrum of ischemic heart disease in women. And you see this infographic from Dr. Leslie Shaw highlighting across that cardiovascular disease is pervasive in women across the lifespan, and the focus on imaging for early and targeted care of at-risk women, definitely important. And we have evolving data from the world of cardiac CT, from all of our imaging modalities, including echo, MRI, and nuclear, to help us identify ischemic heart disease in women. So the question we're faced in the clinical world is which patients should be evaluated by non-invasive imaging techniques. How do we, as a clinical team, decide on which imaging modality? Should it be CT? Should it be stress? Should it be stress echo? Should it be MRI or nuclear? And what factors will influence how non-invasive imaging should be repeated? We look at the ischemic cascade on the right, and I always love to go to this because it highlights the fact that the full spectrum of ischemia, by the time you're having chest pain, many of the parameters listed need to be involved. The endothelium, whether we have diastolic dysfunction, all of these factors can be evaluated by our non-invasive techniques. And so as the research has evolved, In the world of non-invasive imaging, we have sophisticated techniques for echo, for nuclear, for cardiac CT, and MRI to really give us the full spectrum, evaluate the full spectrum of factors that cause ischemic heart disease in women. So here is a clinical case that we had the opportunity to take care of, and she was featured in our documentary that you saw the clip of that Dr. Rosen showed yesterday. 55-year-old Afro-Latina woman, came from the Dominican Republic in the Caribbean, mother of 2 teenagers, works at home as a home health aide, and had gone to the emergency room on 3 occasions and had been turned away with a diagnosis of indigestion. She now is coming back in with this 6-month episode. Her symptoms described as typical, located in the mid-chest, brought on by emotional stress, relieved with relaxation, and this is her 4th visit for evaluation of continued chest pain. We look at her medical history and we see gestational diabetes and preeclampsia during her last pregnancy, a family history of coronary artery disease with an older brother who had a PCI to his LAD at age 52, and her labs indicate definitely diabetes and hypercholesterolemia. So what would you do at this point in time? So here's someone, this is her 4th visit, intermittent episode of chest pain, classic symptoms, classic risk factors. Who would choose to do some sort of stress testing, or who would just take her straight to the cath lab? A show of hands, to the cath lab? Okay, all right. Who would do some sort of functional testing? Yes. Mm-hmm.
She does have the risk factors. She has a family history of premature coronary artery disease. She's 55, and she does have the risk factors. Her hemoglobin A1C is 8.5. This is a very, very high hemoglobin A1C, and the LDL is high. So if she has hyperlipidemia, hyperglycemia, and family history, she's already and she's above 50. She already has 4 risk factors. So what do I need more to do? I will not stress her really. I will not do the vitamin. I'm an imaging person, but I will send her for cath.
Okay, all right. So shared decision making came into it, right? So I'll tell you what happened to her in a while. Highlighting the fact that the guidelines have given us evidence and have given us the pathway forward. You can see here, within the past 4 or 5 years, we have seen several guidelines to give us guidance. The 2021 AHA, ACC guidelines signed on by multiple imaging committees, spearheaded by Dr. Martha Galati, gives us the roadmap to how to evaluate the patients with chest pain. Even though there was no specific section for women, sex and gender were included, followed by multimodality imaging approach, as well as the ESC guidelines in 2024. So we have a roadmap and guidelines and algorithms to help us. We also have, and this is just the evidence evolving, to show that when we look at the appropriate use criteria, we could help give guidance in terms of assessing the pretest probability when someone presents with chest pain. And you can see here, whether it's less likely to be angina or not, or non-cardiac, many factors are listed there. And the ESC in their 2024 chest pain guidelines highlighted in the algorithms, and the calculator included chest pain characteristics. So as pointed out, she has several risk factors. Dr. Hannah clearly outlined them, and you see here especially the pregnancy-induced hypertension and the family history. And if we were to do the risk calculator, you can see here the challenges with assessing the pretest probability using some of our traditional risk calculators. These are from the 2021 guidelines, and you would say 50 to 59, her pretest probability still falls in low. It's less than 13, right? And it's assessing her pretest probability based on age, sex, and symptoms, still not adequate. If we were to do cardiac CT, we didn't have time to do that, but I'll tell you what happened. We could definitely, probably would have pushed her risk into the moderate zone. And the ESC guidelines, just if you're in the clinical situation, you can use this. Even using symptoms and the ESC guidelines, she still falls into a low risk, falling somewhere in the sort of green to yellow areas. And the algorithms that exist will say for a patient at low risk that you could pretty much just adjust the clinical likelihood, and you can see there cardiac CT is what's recommended. However, we had a conversation with her, and this was her 4th visit. She was afraid of going to the cath lab, so we did a nuclear stress test. And you have to be cognizant of people's lived experiences and their history. So she had a nuclear stress test. She had been asymptomatic for a long time. And you can see here the polar maps highlighting significant LAD, ischemia, and a cath. She had a very tight stenosis of the LAD. Went on to have a stent, was discharged on the usual meds. And I bring this case to your attention because 3 months later, she comes back in with an acute anterior wall MI. You see her list of medications, and the question was, what had gone wrong? And I will highlight the fact that when we put a stent in, we make our diagnostic tests, our jobs are not complete. And what came to mind was that her language of communication was Spanish. We communicated everything in English. She did not understand that she needed to take dual platelet. She had stopped her aspirin. Because she had heard histories from a neighbor of having a GI bleed, and this was the reason. So I just bring this to your attention to recognize that our patients, there are many barriers to adherence to medical strategy after a diagnostic test, and we have to be cognizant of those factors. So here's a second case. 52-year-old female, history of gestational hypertension at age 40, no medical history, just daily multivitamin was her medications, family history of hypertension, and her mother had a stroke at age 75. She was an investment banker, high-stress job, married with 2 kids, new onset chest pain. And this is her EKG, and if you have to deal with high-stress patients, they come in, they want everything done right away, and you look at her EKG, her baseline ECG, remember, no prior history, uncomplicated pregnancies, and you see diffuse ST segment changes. What would you do at this point in time? Oh. You start with an echo, okay. Exertion, yes, right. Right. So abnormal ECG in a person who is usually physical active with new onset chest pain. So we looked at her risk calculator. You could see here, again, 50 to 59, low risk. What do the guidelines tell us? The guidelines tell us that, and these data from Dr. Galati's publication of the chest pain guidelines in 2021, she's at low risk, right? That you have the ability to ignore, to say low risk, to do nothing or defer testing. What was concerning for the physician, and it's a colleague of mine, was that her baseline EKG was slightly abnormal. And so he decided, Dr. Phillips, to say, okay, let us go to cardiac CT. Now, she refused at that point in time because she wanted answers right away, had a trip planned. And so he decided to just put her on the treadmill because it was easy to do. So this is her simple stress ECG. She completed about 8 minutes of exercise, didn't really reproduce symptoms, but look at the EKG with diffuse ST segment changes that got worse. So at this point in time, we sent her to the cath lab. Dr. Phillips decided to take her to the cath lab. And you can see here, and Dr. Waleed, I apologize, I'm not an interventional cardiologist, so I don't have the moving images, that no obstructive disease, but a lot of lumpy, bumpy disease. And she was told, to go back to see her cardiologist. So she goes back to see Dr. Phillips. What would you do at this point in time? Perfect. And so the idea of someone with chest pain, with some risk factors, who refused, we could do, he discussed with her doing a cardiac CT, but at that point in time it wasn't relevant, so she went to the cath lab. And so why is she still having chest pain? Because she continued to have episodes of chest pains. And so you look at this algorithm, this infographic, and there's several infographics that exist. This is one of my favorite. She falls into the now intermediate risk with ischemia, with no obstructive coronary artery disease, and so functional imaging is definitely necessary. And so she went on to have a PET rubidium scan because they had that readily available. She's 55. They were less worried about radiation and past childbearing age. And so what we have learned in terms of looking at myocardial blood flow, we know that if the coronary flow is abnormal, the ratio is less than 2, that has a worse prognosis in women. That ANOCA in women is not benign, emerging data to show that we once commonly thought that if you had no obstructive disease and having chest pain, it could be non-cardiac or you would have a good prognosis. We know that that is not the case. The data from the WISE trial from Dr. Noel Barry Mieres. Here you see her images, subtle basal abnormalities in the mid-septal perfusion. Her global perfusion was reduced blood flow at 1.97, indicating a horrible, not a benign prognosis. And so as we include ischemia with no obstructive disease, that these are women at risk, they have atherosclerosis, and definitely persistent angina will continue, and factors that increase the likelihood of CMD include diabetes, hypertension, infiltrative heart disease, small coronary vessels. And so the overarching theme is that women that have non-obstructive disease and continued chest pain need to be evaluated because their risk and their prognosis is not benign. So these were just 2 cases to highlight. We didn't discuss cardiac CT, but showed 2 cases to highlight the role of imaging in approaching the woman with chest pain. I think we know that the cardiac imaging tool belt is increasing. We have the ability now to evaluate the full spectrum of ischemic, of coronary artery disease in women, going from the microvasculature to the endothelium to epicardial disease, the coronary microcirculation. We know that in the majority of cases, several different cardiac imaging tests can be performed, and you saw in that case going from an anatomic test to looking for microvascular disease, and knowing the key differences between the tests integral to providing patient-centered care, and local expertise should guide test selection. So we have evolving tools, and you can, in the cath lab, if we had the foresight, we would have definitely done coronary flow reserve in the cath lab, but that was not available at that point in time. So, ladies and gentlemen, hopefully I've given you a quick highlight of the why for continued focus on early and accurate diagnosis. The Lancet just published 2 months ago, a few weeks ago actually, a paper calling on us to move away from the focus on identifying disease when it's already intermediate to really focusing on atherosclerosis and the atheroma and to implement preventive strategies. So thank you very much for your attention and look forward to the discussion.